Looks like we should get started. So first of all, I'm Kerrie Webb, Senior Staff Counsel at the Medical Board. And thank you all so much for joining us today for the Interested Parties meeting. We've got two agenda items. The one that I expect will take some time are the regulations for Business and Professions Code, Section 2507, and then also the hospital reporting form. We may have time to get to that as well. Many of you have written comments, and the majority of the comments, which is not a surprise, has been directed to the issue of VBACs and midwives being able to do VBACs without a required physician consult and sign off. So I think if we can make headway on that issue, we'll be doing great work. And for now, I would like to get any further updates from the ACOG and CAM as to whether an agreement has been made or where we should begin the discussion on that.
No agreement on VBACs.
Okay.
I'm John Wachtell. I'm the ACOG District 9 chair, and Lori Gray preceded me. I'm probably familiar with Lori anyway. I'm sort of replaced Lori as chair for ACOG District 9, so we're here to represent ACOG. And the ACOG policy on VBAC is pretty clear, that the committee opinion that we have published, and I'm here only to represent ACOG in their opinion, not my own personal opinion. So the published opinion is that ACOG feels that VBAC is a contraindication to home birth, and that's the policy that we would recommend.
Okay. Well, I think what we have to address in this, and it's a glaring word in the section, and that is any pre-existing maternal disease or condition likely to affect the pregnancy. And when we put together the proposed regulations, and it goes through the whole lengthy process of getting reviewed and approved by the Office of Administrative Law, the board is going to have support for each of those line items. And, been reviewing comments and peer-reviewed studies, and I recognize that there are risks associated with VBAC if something goes wrong, but it seems from the studies that it's not likely something will go wrong, especially if there is one prior C-section with a low transverse incision. And so if ACOG is going to take the position that has to have a physician consult and sign off, there has to be support for that to rely on. Otherwise, within the comments that we will get, the board isn't going to be able to justify having that in. And so maybe I can get a response from you on that. Maybe you have to take that back to ACOG and respond at another time. But that's going to be a significant issue for us, and the regulations won't be approved with that in it without support.
Well, I mean, this has certainly been reviewed repeatedly over the years at ACOG nationally by different groups of experts that, you know how ACOG works, but they have committees, and there's a committee on obstetrical practice, which is 10 to 15 experts from around the country, and people rotate every 3 years, so you get different opinions coming on. And each time the VBAC issues come up, the conclusion has been the same. When our maternal fetal medicine experts have reviewed the data about the risks and potential complications. And of course, the problem is that the serious complication of uterine ruptures are unpredictable, unpreventable events, which can be catastrophic. They happen in the hospital and have a obviously much higher likelihood of being catastrophic for mother and or baby if it were to happen at home. And obviously, when you're talking about likelihoods, there are very few things that we do in modern day obstetrics that would carry the same risk of VBAC. And just based on the risk factors and the unpredictability and the need for truly emergent care, again, we're just looking at it from a patient safety standpoint and trying to make it as safe as possible. There's no desire to limit women's options. What we're trying to do is make that option as safe as possible.
If I can make I think we're getting back to the issue of the definition of the word likely for any of these conditions. And if you look at all of them, for instance, history of postpartum hemorrhage requiring transfusion, that's not saying, when we drafted the law, we weren't saying likely was a limitation on may affect the pregnancy. It was not a preponderance of evidence likely. So for instance, these other conditions, these are not conditions that necessarily, requiring a hemorrhage, requiring transfusion, that it was a 51% chance, on any of these. So if we need to go back in and do a legislative fix to add clarity, but I think that we can work with the author's office in terms of showing legislative intent, was we were trying to have it be not so broad that every woman was going to require a consultation. Because if we did say, which I believe is the language in the standards, about if it's something that's that may affect the pregnancy, that could be just about anything. So if you look at it, when you're defining likely as looking at these other situations, and are they putting them in the same category to judge whether or not you've got a risk of the pregnancy with the VBAC. But also, this is not, even though ACOG policy is not supportive of home VBAC, we specifically drafted the legislation not to prohibit VBAC, but you need a consultation. And that's all we're saying, is that this previous C-section is you need to have a physician consultation. And you don't have to have the physician say, yes, we're saying that this is okay for home birth. We're just saying, having the physician sign off on his or her understanding about, how the previous C-section is going to impact this pregnancy.
When you say sign off, does that mean paper, piece of paper?
Well, so one of the things we have to be very careful about is because of all of the liability issues, is we needed to make sure that because there's so many barriers to the midwife and physician consultation, that it would be the woman would go to the physician and have the physician consultation and then get a medical record of that visit, so that she could then have something, because there can't be the verbal interaction for a lot of the physicians, to have something written. Which is there an issue?
Kaiser says they will not write anything down. That privately between the mother and the obstetrician, they say, I don't see that you're any more risk for anything than anybody else is. It's not particular, but I won't write that down. So that means that there's really no medical record other than the fact that they saw their doctor on such and such a date. There's nothing entered into the record. So how does that play out for the licensed midwife if there is an issue later?
I would think this would be like any other consult visit. When you see a patient in the office, you write a note or dictate a note or just document precisely what happened. And I don't know about Kaiser's opinions about that, but I mean, it's pretty standard of care.
They're pretty big.
I understand that the standard of care is to document your visits, and this visit would be no different from any other office visit. just document what,
Yeah, but
what
that
occurred
isn't
with
happening. It's been a whole year, and that isn't happening.
So,
I'd like to hear from ACOG what has changed since 2005 when we drafted a regulation that specified exactly what the protocol was for someone with a prior cesarean who wanted a home birth. It did not include a physician referral in 2005. Why should it include a physician referral now? Where is the data that shows us that suddenly VBAC at home has become more dangerous in 2014 than it was in 2005 when ACOG agreed to that regulation? And I'm sure Ms. Webb probably has the regulation number if somebody needs it. But I just really would like to know what's changed.
I believe what's changed is that there's no longer supervision that's required. And so the idea is to, again, to make this as safe as possible, to have a physician decide that this is safe for the patient.
With respect, in 2005, it was well understood by the crafters of that regulation, many of which are in this room, that midwives in California did not have supervision. And the regulation was put in place as a protective measure then because it was recognized we could not get physician supervision. So that argument's not valid, I'm sorry.
if I can also speak to that, I think because I was in the room, and part of that is we objected to the informed refusal to do home VBACs at the time. And we were told this regulation is going through with or without us. And so all we were able to get was what was currently in regulation, which is having the ACOG document that the midwife can give to the patients. That was not us drafting a regulation that we thought was the best regulation. We were making the best out of a situation that we didn't agree with.
Okay, but we now are 9 years on from that regulation, and I'd like to know where is the evidence that shows it doesn't work?
Well, you've got, you know what, there's certain cases, I'm not sure if I want to talk about in public, but there have been some disasters.
I'm going to make a comment about the VBACs. As Chief of Licensing, and I have the support of the Executive Director on this, licensed midwives have been doing home birth for mothers who've had a VBAC, prior VBAC, that meet the low transverse. Prior cesarean, sorry, for a long time. Their data doesn't show a problem with doing that. So, in order to help this move along, you can sort of expect to see that still continuing, because I am the one who has to present the regulations, and I am the one who has to sign what's going forward. Our board member has been one of our board members has been around since that started. She's very supportive of that also. I don't think the argument that you have to see somebody because there's no supervision now, they didn't have supervision before. So it was, even though in law there was already a court case that said you couldn't hold the midwives to that law because the obstetricians could not supervise them because of their insurance limitations. So I think we're going to sort of, you want to talk about other types of VBACs where there's been multiple cesareans, that's a little bit different. But the one that I'm talking about, which I plan on seeing in the reg, will be the one cesarean low transverse. So I last time spent almost 4 hours on this subject, and we're not going to spend, I don't think, 4 hours on this. I think we need to get to some of the other options that are here that we might come more close to agreeing on. But at the same time, we're not going to drag the regulations out for years and trying to do that like has happened in the past. I was around when that all happened before, and I don't want to see that happen collect data for the midwives every year, and their outcomes are very well. So I don't think we can say, because there is maybe 1 or 2 or small percentages of bad outcomes, you can say that for the physicians as well. So I don't want to belabor this particular issue. If you have something that you think might change my mind, you're more than welcome to state that. But I'm going to be very hard to convince when I've been around the midwifery community long enough to know it's really not been an issue for one cesarean.
One question, we've had an ongoing issue about some of the data in terms of fetal demise, about being able to, if there's a fetal demise after the pregnancy, how if that is accurately recorded. So that may be something also that we want to go back and look over, because apparently there was also some issue about being able to declare, well, actually not fetal demise, infant demise.
The LMAR is in the process of being looked at and via task force. It's a member of the advisory council. We're working on addressing the inconsistencies in the reporting. But even if you contributed all of the transfers that might possibly be related to a VBAC gone wrong, it's a very small number.
Well, I would hope that those aren't small numbers, and there's small numbers for everyone, whether it's 0.5% or 1% number you choose to pull out of the literature. Yeah, the 99% of the time things are going to go well, so you would expect in absolute numbers that it's not going to happen very often. The problem is the catastrophic nature of those bad outcomes and whether those can be managed in a safe fashion. So I think when you're talking about likelihoods, I mean, 99% sounds pretty safe. And if you were getting on an airplane at San Francisco airport and the pilot came out and said, we've got this minor maintenance problem and there's only a 1% chance that we're not going to crash, if you're saying to get off that plane, because no airplane would take off with a 1% risk, there'd be 5 fatal crashes a day out of San Francisco airport. And so I think you have to put everything into context. And yes, the absolute numbers are small, but you're still increasing the risk for a catastrophic outcome.
Can I say something?
Please.
Okay. Should I identify myself?
Yes.
Hold on a second, because we did have a hand over here.
Well, I just wanted to say, yes, I'm Jen Kamel, founder of VBAC Facts, and I just wanted to say that in your situation, you would have the opportunity to get on another plane. When women are pregnant after cesarean, they often don't have the opportunity to just go to whatever hospital they want to go to, given that 44% of California hospitals ban VBAC. So many women are seeking out-of-hospital VBAC because there's no other plane for them to go on.
And then I think Kerrie, and she's, can you identify yourself too?
Yeah, my name is Dr. Stuart Fishbein. I'm an OBGYN in practice in Southern California. I'm a fellow of the American College of Obstetrics and Gynecology. I spent my first 28 years working in hospital-based obstetrical practice. I did my residency at Cedars-Sinai Medical Center in Los Angeles. For the last 4.5 years, I've been doing home birthing. So I have fairly unique insight into the differences between the two types of practices. I can tell you from the very beginning that I didn't learn anything in residency about normal birthing, that they don't teach normal birthing in residencies. Residents don't see normal birthing. I had to unlearn and relearn a lot of the things that I know. But in response to the comment by Dr. Wachtel, he's basically saying that the risk of a catastrophic outcome is rare, and it's not predictable, if I'm saying that correctly. Right? I don't understand how a consult earlier in the pregnancy is going to be of any use then whatsoever. It makes no sense to me as an obstetrician that I'm going to say somebody at 20 weeks, and I'm going to say, oh, she's okay for a VBAC, and then she may have a catastrophic outcome. How did that change the outcome? What purpose did it serve to do that? I have a whole lot of stuff prepared here, but I'll just stop there for now and hopefully chime in as we go along, because I have a lot of data about the Committee on Obstetric Practice, too, and their 1999 guideline that said that emergency help should be readily, instead of readily available, immediately available, and that got the whole obstetrical world in a tiz back then. And that was actually based on level C evidence, and I think probably it's been explained here maybe by Jen and some other people, that level C evidence is not based on any science, it's based on consensus opinion.